Okay, so we're going a little bit out of order, but the last lecture was on contrast agents, so I thought we would start with MRI of the liver with gadoxetate, and this is a little bit of a continuation of the prior lecture. Why is this not moving forward? Okay. All right, so on the last lecture, we talked about the entire landscape of gadolinium-based contrast agents, of all contrast agents in the United States. Shown here is a landscape of gadolinium-based contrast agents specifically. You can see that the very first contrast agent approved in the United States was approved in 1988, gadolinium attached to a particular chelator called DTPA, commercially known as Magnavist. That was 1988. The most recent gadolinium-based contrast agent approved in the United States, 2013. This particular formulation of gadolinium, it's attached to a chelator named DOTA. But today, in this lecture, we're going to focus on gadolinium EOB DTPA, which is known generically as gadoxetate disodium. It's known commercially as Primavist in the rest of the world. It's known commercially as Eovist in the United States. So in this lecture, we'll ask, what is gadoxetate and how does it differ from conventional extracellular agents? We'll review a basic MRI protocol using gadoxetate, understand its potential advantages and disadvantages in patients without cirrhosis, and then in patients with cirrhosis or otherwise at risk for HCC, become familiar with some of its limitations and pitfalls, and review one institution's, namely ours, decision tree for when to use it and when not to use it. So here's the chemical structure of gadolinium DTPA. This is that first contrast agent that was approved in the United States, commercially known as Magnavist. And why is the gadolinium chelated to a chelator? Again, because gadolinium is toxic, so we chelate it to maintain its safety. Now, if we take DTPA, which is the backbone shown here, and we add an ethoxybenzyl group to it, or EOB, we now have gadolinium DTPA EOB. And in the literature, it's often referred to as gadolinium EOB. So if you ever hear someone talking about gadolinium EOB, they're talking about this particular contrast agent, gadolinium DTPA EOB, which is commercially known as Eovist in the United States, Primavist in the rest of the world, and generically known as gadoxetate disodium. It's sometimes also known by its acid name, gadoxetic acid. So all of those are the same: gadoxetic acid, gadoxetate disodium, gadolinium EOB, Eovist, Primavist, all different ways of saying the same thing. Now, gadolinium EOB DTPA gradually accumulates in liver cells via particular transporters known as OATP. So OATP are these transporters that are on the they're on the sinusoidal membrane of hepatocytes. OATP, organic anion transporter polypeptides. Notice that hepatocytes have other transporters, including the multi-drug resistance associated protein 2, which excretes things into the bile duct canaliculus, as well as another exporter known as multi-drug resistance associated protein 3, which spits things out back into the sinusoidal space. So recall the microanatomy of the liver. We have hepatocytes forming rows. The hepatocytes have an epithelial surface which faces the perisinusoidal space. This perisinusoidal space is separated from the sinusoid by these endothelial cells. And the sinusoid is to the liver what the capillary is to the rest of the body. So the sinusoids of the liver, it's another way of just saying the capillaries of the liver. So when we first give gadolinium EOP DTPA, it will distribute in the extracellular space, so it won't go inside the cells right away. Initially, it will be in the sinusoid and in the perisinusoidal space, and it looks like this. So this is what happens when you first give the contrast agent. Now, over time, the contrast agent, gadolinium EOB, is recognized by the OATP transporters and literally gets inside the cells via these transporters. And these transporters live on hepatocytes. They live on hepatocytes in the normal liver. They live in hepatocytes in the cirrhotic liver. And they live in hepatocytes in some hepatocellular lesions. Now, then this contrast agent will be excreted either back into the sinusoid via MRP3 or excreted into the bile ducts by MRP2. And over time, as more and more of the contrast agent gets inside the liver cells, it gets cleared from the extracellular space until eventually most of the contrast agent is either in the liver cells or in the bile ducts, or it's nowhere else, right? Because notice that it's been cleared from the extracellular space. And we might imagine then that if we give this contrast agent after a long amount of time, the liver will be quite bright because the liver cells are everywhere in the liver, but the blood vessels eventually will be dark because this contrast agent gets cleared from the blood space. In fact, gadolinium DTPA EOB gets cleared by both the kidneys and the liver. So this contrast agent gets excreted by the kidneys. This contrast agent gets taken up by the liver via OATP and then excreted into the bile ducts via MRP2. And these molecular transporters account for hepatic uptake and hepatic excretion. And EOB also binds to proteins. Why is the binding to proteins important? Because it reduces that tumbling rate so that gadolinium DTPA EOB becomes a very effective contrast agent, very high relaxivity. So gadolinium DTPA causes a lot of bang for the buck. Let's now focus on OATP and MRP2. So lesions, so the liver gets bright because it has OATP. Any lesion with OATP, any tumor with OATP on its cells will also get bright, but lesions without OATP will get dark. And that's really the fundamental thing you need to know about gadoxetate. Things with the transporters get bright, things without the transporters get dark. So what things have OATP expression and what things don't? Well, let's look at the things that do have OATP expression. So normal liver has OATP expression. Most focal nodular hyperplasias have OATP expression. Regenerative nodules have OATP expression. The hepatocytes that are living within a region of perfusion alteration, so-called transient hepatic intensity differences. So wherever you see a perfusion alteration, those hepatocytes tend to have OATP expression. And a small minority of HCCs tend to have OATP expression, maybe about 5%. Pretty much everything else has low or no OATP expression. So things that are not made of hepatocytes, so for example, cysts, hemangiomas, metastases to the liver from other organs, intrahepatic cholangiocarcinomas, these are not made of hepatocytes. These have low or no OATP expression. Similarly, non-hepatocellular tissues like scars, fibrosis, the blood inside a blood vessel, those are not made of hepatocytes. Those also have low or no OATP expression. Some tumors that are made of hepatocytes also have low or no OATP expression. So for example, most adenomas have low or no OATP expression. Most HCCs have low or no ATP expression, and some dysplastic nodules have low or no OATP expression. So you can see now that if you memorize this list of what tends to have and what tends not to have OATP expression, you will be able to predict what you would see when you use this particular contrast agent. Now, some things need to be memorized, but some things don't. So non-hepatocellular lesions, non-hepatocellular tissues, that's a no-brainer. If you know that OATP is expressed in hepatocytes, but not in non-hepatocytes, then this is very easy to remember. This might be a little bit more difficult to remember. So this is what it looks like. Here is a normal liver, and here is a cirrhotic liver. Notice that the normal liver is bright, the cirrhotic liver is bright. Notice that the normal liver tends to be brighter than the cirrhotic liver. And why is that? Because the normal liver tends to have better OATP function than the cirrhotic liver, where the hepatocytes are a little bit damaged by chronic inflammation. Notice also that the normal liver looks fairly homogeneous. The cirrhotic liver tends to look more inhomogeneous because the cirrhotic liver is divided by tiny scars into regenerative nodules. So the individual regenerative nodules, I don't know if you can see my arrow right here, but the individual regenerative nodules are bright, but these individual regenerative nodules are surrounded by fibrosis, and fibrosis is not made of hepatocytes, so the fibrotic scars are dark. Now, this particular normal liver has a lesion, and this particular lesion is a focal nodular hyperplasia. And on the previous slide, I mentioned that 95% or so of focal nodular hyperplasias have high OATP expression, and they will look bright as well. Now, you might look at this FNH and say, well, why does this FNH have this dark thing in the middle? And this dark thing in the middle is a scar. So focal nodular hyperplasias characteristically have a central scar. The scar is not made of hepatocytes, so the scar is also going to be dark. In addition to this scar, they often have this network of fibrotic bands that also divide the nodule into smaller nodules. And so we also have these little dark lines throughout this FNH. Now, this is a hepatocellular carcinoma. You wouldn't be able to figure it out from this one image by itself, but this is a hepatocellular carcinoma, which also tends to have reduced OATP expression in 90–95% of cases, but most HCCs look dark. Now, notice that there's something else that's dark on this image. Notice that the blood vessels are dark. And why are the blood vessels dark? The blood vessels are dark because this contrast agent is excreted not only by the kidneys, but it's also excreted by the liver. So there's a dual mechanism for removing this contrast agent from the blood. One is the kidneys and one is the liver, and that causes the blood vessels to get dark quite quickly. If we had given a different kind of contrast agent, an extracellular agent, the blood vessels would be brighter than the liver. Okay. Now, another thing you'll notice is that the bile duct is bright. And why is the bile duct bright? Because this contrast agent gets excreted by so-called transporters called MRP2 into the bile ducts. So the bile ducts are also going to be bright. And by the way, I don't know if you can appreciate it. Here's a bright bile duct right there in the normal liver. Now, here are two different cirrhotic livers. This cirrhotic liver is a well-functioning liver, and it's well-functioning because you can see that the liver is much brighter than the blood vessels, indicating that this liver is able to extract the contrast agent effectively from the blood vessels. And that's why this is a well-functioning liver. Now, this liver is not a well-functioning liver. This liver is a decompensated liver. The more advanced radiologists in the room can also appreciate the fact that there's some ascites over here, which is another manifestation of decompensation. Now, how do I know this liver is not functioning well? Because I look at the liver and I look at the portal vein, and I see that this liver is barely brighter than the portal vein. So this liver is not very good at extracting the contrast agent from the portal vein. Therefore, this liver is poorly functioning. This liver is well functioning. And now, why is that important to a radiologist? Well, one reason it's important is that if you have an image that looks like this, where the liver is much brighter than the portal vein, you know you can trust the information from this image. Here, where the liver is barely bright in the portal vein, you know this liver is not working very well. You know that this image is going to be a little harder to trust. It might be harder to see a lesion, even if there really is a lesion. Now, I know what some of you are thinking. You're saying, oh, wait a second, Claude. How can you say this liver is poorly functioning? Because look at that bile duct. That bile duct is so bright. So clearly, this liver was able to take the contrast agent out of the blood and spit it out into the bile duct. So why are you saying this liver is not functioning well? Well, there's something else you need to know about the cirrhotic liver. The cirrhotic liver tends to have slightly underexpression of OATP, but it has overexpression of MRP2. Again, MRP2 is a transporter that excretes junk out of liver cells. Sometimes the junk is this contrast agent, gadolinium EOB, but sometimes the junk is toxins that might accumulate. So if you were evolution, or maybe not evolution, but if you were a cirrhotic liver and you wanted to sort of stay alive, you would want to start overexpressing MRP2 so that the toxins that your cirrhotic liver is producing get out of the cells. So the point being that in the cirrhotic liver, the OATP expression is down, so not that much contrast gets into the liver cells, but whatever contrast gets into the liver cells gets excreted because there's overexpression of MRP2. Now, for those of you who are not following all this alphabet soup of mumbo jumbo, remember this. Do not look at the bile duct as a feature of imaging quality. Even a crappy image might have intense excretion of the bile duct. Instead, don't look at the bile duct to tell you whether or not this is an adequate hepatobiliary phase. Look at the liver, the liver, the portal vein signal intensity ratio. Let me skip this in the interest of time, and I will move to this. Okay. So what I want to show you now is the difference between an extracellular agent above and gadoxetate below. Pre-contrast, of course, they both look the same. And notice that both contrast agents look the same in the arterial phase at 30 seconds. Notice they both look the same at 40 seconds. It'd be pretty difficult to know which kind of contrast agent you were looking at 30 seconds or 40 seconds. That makes sense because initially the contrast agents are in the extracellular space. However, by the time you get to the portal venous phase, you might appreciate that the liver is already a little bit brighter than the liver is with the extracellular agent because these liver cells are starting to suck the contrast agent into the cells via OATP expression. But the difference is pretty subtle in the so-called portal venous phase. By the time we get to 3 minutes, so it's more obvious. Notice that the blood vessels are still much brighter than the liver with an extracellular agent. Notice that with EOB, the blood vessels are now about the same signal intensity as liver. You can barely see the blood vessels inside the liver. Notice how obvious the blood vessels are with the extracellular agent. And by the time you get to many minutes of delay, notice that with the extracellular agent, the blood vessels are still brighter than the liver. But now notice that with EOB, the blood vessels are now darker than the liver. And notice that we now have excretion into the bile ducts. So the liver progressively gets brighter and brighter and brighter. I'm sorry, with EOB, the liver gets progressively brighter and brighter and brighter. With extracellular agents, the liver peaks in its enhancement in the portal venous phase and then starts to get slightly darker subsequently. Now, these are normal livers. And I should say something else. How do let's see. There we go. Okay, so this is called the hepatobiliary phase because the contrast agent is mainly in the liver cells. And this is the portal venous phase because the liver is maximally enhanced. So at this point, the contrast agent is mainly extracellular. At this point, the contrast agent is mainly intracellular. So between here and here, the agent goes from, or transitions from extracellular to intracellular. So this phase over here, when it's transitioning from extracellular to intracellular, is known as the transitional phase. So the delayed phase is hepatobiliary, and this phase in between is called the transitional phase. So whenever we talk about the transitional phase, we're talking about images about 2, 3, 4, 5 minutes after giving the contrast agent, in which there's contrast both in the extracellular space, you see how the blood vessels are still bright, and in the liver cells, as opposed to the phases before and after. Now this is what it looks like with a cirrhotic liver, extracellular agent above, gadoxetate below. Again, in the arterial phase, they look quite similar. In the portal venous phase, we start to see a difference where the liver looks a little bit brighter here than it does here. And then notice the difference in the hepatobiliary phase, blood vessel dark, blood vessel bright, bile duct bright, and also notice that here we see bright fibrotic scars, and here the fibrotic scars are dark. Now, some of you might be looking at this and wondering if these are bile ducts over here, and these are not bile ducts. These are lymphatic channels. So that's a more advanced topic, but extracellular agents will get into the lymphatic channels, and you'll see the lymphatic channels in the liver. Let's ignore those for now. This is biliary excretion over here. And for those of you who are radiologists, the distinction between the bile duct and lymphatics is very easy. For those of you who are radiologists, you're probably looking at them saying, how can I tell them apart? Just trust me, it's very easy for a radiologist to tell the difference between lymphatic channels and bile ducts. Okay, and then this is yet one more example of a cirrhotic liver extracellular agent, Gadoxetate. This particular cirrhotic liver has bands of fibrosis that cause the liver to retract inwards. And notice that these bands of fibrosis are bright with the extracellular agent. Notice that those bands of fibrosis are dark with Gadoxetate because those bands of fibrosis are not made of hepatocytes. Okay, so we discussed what is Gadoxetate. Let's quickly review a basic MRI protocol. So a basic MRI protocol is we collect a coronal single shot, an axial out of phase and in phase, and optionally we do a T2 weighted MRCP. We then do pre-contrast T1 weighted imaging. We give the Gadoxetate, talk about this a little bit more in just a second. And then at UCSD, we typically do 2 or 3 arterial phase passes with a fixed 30-second window. We then get portal venous phase imaging, ideally at about 70 seconds. We then get transitional phase imaging at about 2 minutes or maybe 3 minutes. We then do our T2 and our DWI. And then we get hepatobiliary phase imaging at 15 to 25 minutes. If we want to look for bile leaks, which is off-label use of the product, we get images at 1 to 6 hours. In terms of giving the contrast agent, we give an FDA-approved dose at 1 ml per second and chase it with saline at 30 to 40 mLs. I don't want to get into these details today, but if anyone's interested in these details, we can have a more detailed discussion about some of these technical factors. Now, I mentioned this earlier, that the reason that I do the T2 and the DWI after giving the gadolinium, there's a couple reasons why I do it. Notice here that the transitional phase is at 2 minutes or 3 minutes. Notice that the hepatobiliary phase is at 15 or 25 minutes. So there's a gap, right? So what are we going to do in this gap? Well, one thing we could do, I guess, is we could take the patient off the scanner, put them back on the scanner, but that's a very inefficient thing to do. And then when you put them back on the scanner, they're not going to be in the same position. It's too complicated. So during this gap, this is when we do our T2 weighted imaging. This is when we do our diffusion weighted imaging. This is where we do our iron imaging and our proton density fat fraction imaging, because we have to sort of wait anyway. And then we do our hepatobiliary phase. And the DWI looks the same pre and post, so there's no reason to do it pre. You might as well do it post. The T2 weighted imaging looks the same pre and post. You might as well do it post. Okay, so we've talked a little bit about a protocol. Let's move on now to advantages and indications, starting with the non-cirrhotic liver. So there's 3 main indications: detection and staging of liver metastases, FNH versus hepatocellular adenoma, and bile leaks and biliary anatomy. These things are off-label use of the product, so I'm not going to talk about those. And I'll just focus on detection and staging of liver metastases and FNH versus hepatocellular adenoma. So let's start with this case over here. This is a patient who has a metastasis in the liver from colon cancer. I don't know if you guys can appreciate the metastasis is right there in segment 4. And this metastasis was diagnosed on a combination of this CT scan and a PET scan, which I'm not going to show. Based on that solitary metastasis, the patient was referred to UCSD for resection of this metastasis. But before we did the resection, we did an MRI with gadolinium EOB, shown here. And now let me show you the hepatobiliary phase. And now let me magnify the hepatobiliary phase and the CT. So again, on CT, this is where the lesion is. So we see that lesion on CT, and we see that lesion on MRI. But notice on MRI, we see a few other lesions, don't we? So we see a few other metastases that are essentially impossible to see on CT. And why is this important? Well, Based on this CT, the surgeon was planning on doing a standard left lobectomy and was planning on removing this much of the liver. But if the patient had, if the surgeon had removed this much of the liver, they would have left some metastatic disease behind. And based on this MRI, they changed their surgical approach to include this metastasis over here. So the ability of gadoxetate disodium to detect additional metastases is a very powerful indication for using gadoxetate disodium in preoperative patients. So if a patient is going to have surgery, in my opinion, it is almost mandatory to do a gadolinium EOB MRI to better figure out just how many metastases there are so that the surgeon can plan his or her operation. Now, another reason for doing gadolinium EOB is when there's a disconnect between the imaging findings and the suspicion for underlying metastatic disease. Here's a woman, she's 58 years old, and she has breast cancer, and she has an elevation of a particular blood test called alkaline phosphatase. Alkaline phosphatase gets elevated in several different situations, but one of them is when there is metastatic disease to the liver. So this patient has an elevated alkaline phosphatase. Based on that, there's high suspicion she has metastases to the liver. This CT was read as negative. And does anyone see a metastasis in this liver? Well, hard to know. So we did an MRI with gadoxetate disodium, and every single one of these black dots that you see in this liver is a metastasis. So we can start counting them. 1, 2, 3, 4. Okay, it's going to take us too long to count. There's 1,000 metastases on this image alone. This patient probably had 10, 20, 30,000 metastases on the liver. And maybe in retrospect, you might wonder, you know, is there something here? Is there something here? But boy, on CT, it's very, very difficult. Now, if you think this is just, okay, well, I thought I added a slide, but I guess I didn't. Okay, so so another indication for MRI with gadoxetate is when there's high clinical suspicion of metastatic disease and the imaging that you do doesn't detect it, then you might want to do an MRI with gadoxetate, and it has a high sensitivity for detecting metastases. Metastases are not made of hepatocytes. Because they're not made of hepatocytes, they look like little black filling defects against a bright liver background. Now, another indication for gadoxetate disodium is to differentiate focal nodular hyperplasia versus hepatocellular adenoma. Focal nodular hyperplasia is a benign tumor that essentially never hemorrhages and never becomes malignant. Hepatocellular adenoma is a benign tumor that sometimes becomes malignant and sometimes hemorrhages and can kill the patient due to exsanguination. So do you think it makes a difference if it was you, whether you had an FNH that would never become a cancer and never kill you from rupture, or whether you had a hepatocellular adenoma that might kill you because it might turn into a cancer or might exsanguinate you? So clearly there's a reason that we care about this distinction. So which one of these is the focal nodular hyperplasia and which one is the hepatocellular adenoma? Both are diffusely hyperenhancing. Both look a little bit like they might have a central scar on this image. Both are a little bit lobulated in their appearance. So which one is which? Well, I can't tell the difference, but when we look at the more delayed images, we can see that one of these takes up OATP and one of these does not. And it turns out that at least 90% of FNHs are isointense or hyperintense in the hepatobiliary phase. More than 90% of adenomas are hypointense in the hepatobiliary phase. So this is an adenoma, and this is an FNH. This patient can be reassured. You have nothing to worry about. Live the rest of your life knowing you have this benign lesion in your liver that will never kill you. It will never turn into a cancer. You'll never bleed to death. This patient has to be told, you have an adenoma. There's a certain risk that this might kill you from malignant transformation or bleeding. We need to do something about it. Now, what to do about it is complicated. I'm not going to get into that controversy, but just be aware that this agent can help you in that distinction. Now, here's another example, hyperenhancing nodule. This nodule sort of fades toward isointensity, and you might wonder whether this is a focal nodular hyperplasia. So is this a focal nodular hyperplasia or not? Well, you bring the patient back for a gadoxetate MRI, and you can see that this nodule is a little bit darker than background liver. So this is not an FNH. This is a hepatocellular adenoma. Now, unfortunately, some adenomas do, if 90% of adenomas do not take up EOB, that means 10% do. So one of these is an FNH and one of these is an adenoma. And can you tell which? Well, let's look at the structure a little bit more. Notice that this one is homogeneous except for a central scar. And this one sort of looks mottled and heterogeneous and doesn't appear to have that nice, well-organized structure of this lesion. So if you know that, then you can say that this one is the adenoma and this one is the FNH. And the teaching point is that the internal architecture matters. So it's good to know the internal architecture of FNHs with EOB. This is an FNH with an extracellular agent. This is an FNH with EOB. And notice this internal architecture. The FNH is a large nodule that's divided into smaller nodules by a central scar and a radiating network of fibrotic scars. And if you memorize that internal architecture, then that's another thing that can help you in the distinction. So here are 6 different focal nodular hyperplasias with EOB. And if you sort of visually memorize this range of different architectures, this will help you in the distinction between FNH and the rare dysplastic hepatocellular adenoma that takes up EOB. Okay, let's shift gears from the non-cirrhotic liver to the cirrhotic liver. Advantages and indications of EOB in the cirrhotic liver is that it can differentiate vascular pseudolesions from small HCCs. It can help you diagnose hypovascular HCC, and it can help you identify early HCC and high-risk nodules. So we're going to go through each one of these 3 things in turn, starting with the first. But before we do that, let's just review what a normal HCC looks like, a classic HCC looks like with this agent. So a classic HCC will enhance in the arterial phase, and this is a late arterial phase image because we see contrast in the portal vein. A classic HCC will wash out to become darker than background liver in the portal venous phase, and we'll sometimes see this rim of enhancement in the portal venous in the transitional phase, which is known as an enhancing capsule appearance, which is another feature of classic HCC. And classic HCCs, although they're made of hepatocytes, these hepatocytes have lost the ability to express OATP, and they tend to look dark in the hepatobiliary phase. This is a good quality hepatobiliary phase because even though the liver is cirrhotic, notice that the liver is much brighter than the portal veins in the background. So this is a classic HCC. Okay, so here we have a classic HCC, right? It's hyper-enhancing in the arterial phase. Notice that in the portal venous phase, it's dark, it washes out, and it looks dark in the hepatobiliary phase. So this is a classic HCC. And here's another HCC, maybe not quite so classic, but here we see a mass. And notice that this mass washes out to become darker than liver and portal venous phase and doesn't take up the contrast agent in the hepatobiliary phase. So that's an HCC, that's an HCC. Okay, that's easy. But what about that thing? And what about that thing? One of those is an HCC, and one of them is not. One of them is a little nodular pseudolesion due to an abnormal microscopic connection between an artery and a vein, sometimes known as an arterial portal shunt. An arterial portal shunt is benign, a cancer is malignant. So the distinction between a cancer and an arterial portal shunt is pretty important, right? One's a cancer, one's benign. So which is which? Well, let's start with this one over here, and let's go to the hepatobiliary phase. And look, we see nothing. So that one is benign. What about the other one? Well, the other one, look at that. There's a small little filling defect right there. So this one is a cancer. The other one is a perfusion alteration. So this agent can help you problem solve when you see things like this and you're not sure if they're cancers or not. You can bring the patient back for Gadoxetate disodium, and it can help you figure out whether the lesion is a pseudo-lesion or a real lesion. Now, here's another reason to give Gadoxetate disodium. It can help you detect minimally hypervascular HCC. Now, here's a very obvious cancer that I'm sure all of you can see. And you're probably wondering why I'm showing you such an obvious cancer. So anyway, bear with me as I show you this obvious cancer. And my guess is most of you don't see the obvious cancer in this obvious case. So let's now bring the patient in for an MRI with an extracellular agent. And some of you now may be able to see this cancer. And I'll just tell you where it is. It's right here. So you see this faint hyperenhancement right there and faint washout. So here's the cancer. So when I point at it, right, you can see it. But if you had 30 MRIs to read in a day, and this patient had 1,000 images, and this is the one set of images that shows it, you can imagine how someone might miss this. So this was missed. But this patient was going to have surgery, so we did an EOB MRI, and now I think everyone can see the obvious EOB defect right here. That's very obvious. Once you see this, you can see that it's hyperenhancing. Once you see it here, you can see it here. Once you see it here, you can see it here. And then you go back to the CT and say, aha, there it is. There it is. But who here saw it the first time around? I certainly didn't. So anyway, minimally hypervascular HCCs are important because they're cancers, but they can be missed, and EOB can help. So if you're not convinced, here's another case. Anyone see the cancer? So this patient has a 3-centimeter cancer in the liver. Anyone see it? Well, let's bring the patient back for EOB MRI, and there it is. So now that we see it, we can sort of hallucinate that it was here all along. Now, this particular one is not hyper-enhancing, and so I can't prove it's an HCC from imaging alone. So this patient, I'm getting a biopsy, but this was a cancer completely missed prospectively on the regular MRI. Now, that brings us to a new topic, which is early HCC and high-risk nodules. So this is this is what is known as multi-step hepatocarcinogenesis, in which we start with benign cirrhotic nodules that over time can become low-grade dysplastic nodules, that over time can become high-grade dysplastic nodules, that over time can become early HCCs, and these early HCCs can eventually become progressed HCCs. And these high-grade dysplastic nodules are considered high risk because they have a very high probability of turning into early HCCs. And early HCCs are carcinoma in situ. They're sort of micro-invasive cancers that, if left alone, will eventually become progressed HCCs, which will then metastasize and kill the patient. So we want to be able to detect high-grade dysplastic nodules in early HCCs because these are pretty easy to treat before they become progressed HCCs, which can kill the patient. So if that was too complicated, just theoretically imagine that there's a range of hepatocarcinogenesis from benign to malignant. And now let's ask ourselves, during that range of hepatocarcinogenesis, what happens to arterial flow? Well, arterial flow initially decreases and then goes up. What about OATP expression? What happens to OAT expression during this conceptual progression of carcinogenesis? OATP expression usually declines, and notice that the decline is progressive, and notice that the decline starts early. So if we wanted to pick up pre-malignant nodules, we could pick them up by targeting OATP, and these nodules will look darker than background liver very early in the course of their malignant transformation. But if we're trying to detect nodules by arterial flow, we can't detect them this early, can we? Because notice that at this point, the arterial flow is the same as that of background liver. We can't detect cancers by arterial flow until later in carcinogenesis. And so here's an example of a patient with a cancer. This is an MRI with gadoxetate disodium. And I want to draw your attention to the hepatobiliary phase. And can everyone appreciate that there's a 9-millimeter nodule in this liver? This ends up being an HCC, and this HCC is obvious due to OATP underexpression. I now want to draw your attention to the dynamic phases. And can anyone see the HCC here? And the answer is no, you can't. You cannot see the HCC because this particular cancer has not yet had an abnormality, an alteration in its arterial flow. Now, this particular cancer is also visible on DWI, which will be a topic of a later lecture in today's marathon. So, bottom line is that OATP can pick up cancers before they develop vascular alterations. So here's an example. This patient has a 14-millimeter nodule. Does anyone see it on any of these images? We have arterial phase, portal venous phase, pre-contrast in and out of phase, T2 diffusion. Does anyone see the 14-millimeter nodule? The answer is no, you don't. But the 14-millimeter nodule is right here. So there it is. So now we see this nodule. It's a hepatobiliary phase hypointense nodule without any other abnormality. In the literature, it turns out that about half of these are high-grade dysplastic nodules, and about half of these are early HCCs, and these have a pretty high risk of malignant transformation. So whenever we see them, we get a 6-month follow-up. In this particular case, we got a follow-up 9 months later, and here's the follow-up. 9 months later, it grew from 14 millimeters to 22 millimeters, and now notice that it has hyperenhancement. So it's now a full-fledged progressed HCC that needs to be treated right away. So detecting this was helpful because it alerted us to the fact that this patient is at risk for HCC development, and it allowed us to get a prompt, 6-month, or in this case, 9-month follow-up. Just to show you that this is not a United States only phenomenon, this is a case from Brazil. So here we have a 5-millimeter nodule on the hepatobiliary phase. Notice that this nodule does not really enhance in the arterial phase. This is considered a LIRADS 3. So this patient was followed, and 2 years later, this nodule is now bigger. It now hyperenhances, and this is now a LIRADS 5 or an HCC. Okay, so those are some of the advantages and indications of gadoxetate, but this contrast agent is not perfect. It has limitations and pitfalls. In patients without cirrhosis, what are the pitfalls? This contrast agent is expensive. It's about 2 or 3 times more expensive than extracellular agents. For reasons I'm not going to talk about today, the arterial phase can be difficult to time, and there may be frequent artifacts. Liver enhancement is impaired in iron overload, and this weird transitional phase can be a little bit difficult for radiologists to understand. Now, in patients with cirrhosis at risk for HCC, we have the same 4 limitations, but now we have a few more. And those limitations that liver uptake is often inadequate. Some HCCs, if 90 to 95% of HCCs don't have OATP expression, that means 5 to 10% do, and those can cause confusion. It can be difficult to differentiate HCC from other lesions. I will not talk about that. Infiltrative HCC can be very difficult to detect, and washout in capsule can be more difficult to verify. So let's just go over a few of these. This case illustrates the fact that patients given gadoxetate, for some reason, sometimes cannot hold their breath as well. So this particular patient had an MRI 2 days apart. Extracellular agent above, gadoxetate below, and notice that pre-contrast, the images are of equal quality. In the portal venous phase, they're of equal quality. At 3 minutes, they're of equal quality. But notice in the arterial phase, this image is essentially perfect. I don't know if you can appreciate it, but the patient couldn't hold her breath the whole time, and this image has motion degradation. Now, in this case, it's not too bad, but notice that it's bad enough that it's hard to tell whether there's an enhancing nodule here. So here we see that there's 2 different enhancing nodules. Here, because of the motion, it's harder to tell that this patient has enhancing nodules. So this motion artifact interfered with our ability to evaluate these 2 lesions. Now, we don't yet understand why, but we know that when you give patients gadoxetate, they cannot hold their breath as long. So if someone normally can hold their breath for 50 seconds, after giving gadoxetate, they can only hold their breath for 40 seconds. So you'd never see that on MRI because we never do 40-second breath holds. But we often do 15-second breath holds. If someone can normally hold their breath for 20 seconds and you give them gadoxetate, then they can only hold their breath for 10 seconds. So now you went from having a little bit of buffer to having the absence of buffer, and patients can't hold their breath for the full time. And we still don't understand what causes this physiologically. This is just to illustrate that when patients have iron overload, and this is an R2 star map to illustrate how high the iron level is, then gadoxetate doesn't work so well. When you look at these images, you might be saying, this doesn't even look like a gadoxetate MRI. The blood vessels are brighter than the liver. How can you know that this is a gadoxetate MRI? And I know it's a gadoxetate MRI because I can see the gadoxetate in these bile ducts. So the problem when you have iron overload is not that the liver cells can't take up the gadoxetate, it's that the R2 star, the iron in the liver, causes so much signal loss that you lose whatever signal you gain from the gadoxetate, you lose because of the iron overload. So the liver is functioning just fine, but the liver looks dark because of the iron in the liver cells. Another limitation is patients with poor liver function. So this patient above has good liver function. This patient below with cirrhosis has bad liver function. And just to magnify these two images, and you've seen these images before, you can see the difference. With good liver function, the liver is much brighter than the portal vein. And you can imagine that if there was a dark nodule here, it'd be very easy to see. Here, the liver is no darker than the portal vein. And you can imagine that what might have been a dark nodule here, the same darkness as the portal vein, here might be a gray nodule, same darkness as the portal vein. So this liver, we may not be able to see with a lesion due to its bad function. And this is an example of how gadoxetate can be bad at seeing an infiltrative HCC. So this patient has an infiltrative HCC, and it's very difficult to tell with this scan with gadoxetate disodium. Now, I'll tell you that this is the cancer in the liver in red, and notice how difficult it is to see with gadoxetate disodium in the hepatobiliary phase. We basically don't see it at all. So gadoxetate is not so good at detecting infiltrative cancers. Another limitation is shown here. So here we have a cancer, 12 millimeter cancer with an extracellular agent and with gadoxetate. Notice in this particular case, the patient was able to hold his or her breath. So this is a good quality arterial phase with gadoxetate, good quality arterial phase with an extracellular agent. Then we go to the more delayed images and notice that this lesion is washing out, this lesion is washing out. So far, so good. But notice that with the extracellular agent, we see this rim-enhancing capsule. And so this lesion has a capsule and washout. What about this lesion? Does this lesion show a capsule? I can't see the capsule, right? Can you appreciate the fact that we see this rim of enhancement here, but we don't see the rim of enhancement here? Why not? The reason we don't see the rim of enhancement here is that the liver is so bright that the rim of enhancement of the capsule blends imperceptibly into the background liver, and we don't see capsule. And why is that important? Because if you see the capsule, you can call this a LIRADS 5. If you don't see the capsule, you have to call it a LIRADS 4. So same exact lesion within 2 weeks, with one contrast agent, you can call it an LR5. With a different contrast agent, you can only call it an LR4. Now this is the same example I just showed you with gadoxetate above, but what I want to show you now is something slightly different. So here we have gadoxetate, here we have gadoxetate, here we have a hyper-enhancing nodule, and here, subtle, but we have a hyper-enhancing nodule. And notice that this hyper-enhancing nodule shows up as a hepatobiliary phase defect on the hepatobiliary phase. But in order to score washout, we need to be able to see the hypointensity in the portal venous phase. So there's our arterial phase hyperenhancement. There's the washout. And the question is this lesion washing out? And the answer is, well, it has hypointensity in the transitional phase in the hepatobiliary, but in the portal venous phase, there's no washout. So the point being here that gadoxetate, it's harder to detect washout with gadoxetate because the washout has to be seen in the portal venous phase, and we don't always see it. Okay, so to conclude then, when to give gadoxetate and when not to give gadoxetate. And this is an algorithm that is not based on evidence. This is an algorithm that's based on sort of my opinion. And this slide was put together by a former fellow, Sean Best. So basically, the first question is there a contraindication to gadoxetate? So for example, if the bilirubin is very elevated, and or if the patient previously had a suboptimal hepatobiliary phase, then we'll use an extracellular agent. If the patient previously could not hold his or her breath, and or if the patient has severe iron overload, we know that the gadoxetate won't work so well, so we'll give an extracellular agent. So that's pretty easy. So what if there's no contraindication to gadoxetate? So then we ask ourselves, does the patient have cirrhosis or no cirrhosis? If the patient doesn't have cirrhosis, then we give gadoxetate if we're looking for focal nodular hyperplasia, if we're trying to detect exactly how many metastases someone has because we're doing preoperative planning for metastatic resection, if for some reason we're trying to detect tiny metastases, and although I didn't talk about it, if we're looking for bile leaks, biliomas, or biliary anatomy and living donor candidates, these are the reasons we give gadoxetate. So notice it's just a few things that we give gadoxetate for. Everything else, we give extracellular agents, at least in my opinion. Now, what if the patient has cirrhosis? So then we ask, okay, has the patient had prior local regional therapy like an ablation or a TACE? If the answer is yes, we give an extracellular agent. If the patient has not had a prior treatment, then we ask ourselves, okay, is the MRI being done for surveillance? Are we trying to detect cancer? If we're trying to detect cancer in patients who don't have known cancer, then I'd like to give gadoxetate. Also, what if I do a previous scan and I think I see a pseudo lesion, but I'm not sure if it's a pseudo lesion or a real lesion, then I give gadoxetate. For all other reasons, I give an extracellular agent. So if I'm trying to differentiate HCC from hemangioma or HCC from cholangiocarcinoma, I give an extracellular agent. Or how about this one? If I detect a lesion on ultrasound, CT, or a previous MRI, and I'm trying to stage the cancer, trying to figure out which of these lesions are cancers, then I use an extracellular agent. So for some of you, this might be a little over your head. For some of you, this might be more practical, but this is the decision tree that I use. And I think this is posted in our reading rooms. If it's not posted, then we just need to reprint it and we can post it. Okay, so I hope this review of gadoxetate disodium was useful, at least for those of you who are radiologists and periodically use this contrast agent. So thank you for your attention.